Good afternoon, everyone. Welcome to the Device Clinic webinar series, a special edition. We're going to get started here in a moment as people are getting logged in to the meeting. It's a pleasure to have everyone today. And again, we'll get starting in about 30 seconds or so. Excellent again, and welcome everyone. I'm Greg Lisi on behalf of PrepMD and our guests today. We want to welcome you to the final and special bonus edition to Season 5 of the Device Clinic webinar series. Today, we're going to be focusing on Centennial Heart and their journey to build out a high-performing device clinic. And we're really excited to talk a little bit about the role of the advanced practice provider or the APP in the device clinic and remote monitoring specifically. And we are very, very lucky today to have a great panel with us. Our featured guest today is Julie Box. Julie is the device clinic manager at Centennial Heart in Nashville, Tennessee. Julie leads a team of 14, including advanced practitioners, device RNs, device specialists, medical assistants, as well as admins. Julie took on this role about 3 years ago after working for over 30 years as a device RN. That includes 20 plus years at Centennial Heart and 7 years as a CS with Medtronic. Her decision to take on this leadership role was really driven by the specific goal of building out an APP-focused clinic run by EP-NPs. She's passionate about patients, training, and developing the next generation of device professionals. Julie is joined today by one of her EP-NPs, Kristin Deveau. Kristin has been with Centennial Heart for around 10 years, and prior to working in EP as an advanced practitioner, she developed an extensive background in interventional cardiology as well as working level 1 surgery. She was first exposed to the world of EP working as a traveler. Her first years of working in EP at Centennial Heart were really focused on supporting the EP in the EP lab as well as on the floor. It was not until these most recent 2 years where she began working with devices in the clinic. We're excited to have Kristin share a case study as well as her experience learning and transitioning to working with CIDs in the device clinic as an advanced practitioner. However, before we hear from Julie and Kristin today, I'm excited to introduce Aileen Ferrick. Aileen is the co-author of the 2023 Heart Rhythm Society Consensus Statement and a PrepMD clinical advisor. Aileen is a longtime practitioner caring for patients, for cardiac arrhythmia patients with expertise in cardiac ablation as well as device therapies. She's committed to education, teaching colleagues, residents, and nursing students. She's dedicated to the Heart Rhythm Society, where she has served on most committees, including the Board of Trustees, Scientific Sessions faculty, and currently on the Scientific and Clinical Documents Committee, as well as mentoring upcoming leadership for allied health professionals by co-chairing the LEAP program. She's currently serving on the Workforce Task Force, really looking to solve the problem around the future of manning EP across the space, and I think that really makes today's topic very relevant. So as we focus in on today's topic, we'll be going through the guidelines, talking about the role of the APP, the role of validating and the importance of validating competency in clinic inside of the clinic, and particularly how did Centennial Heart go about that in their journey of expanding the role of the advanced practitioner in EP. We're excited to have you all here join us today, and with that, I will turn things over to Aileen, who will walk us through an introduction of the guidelines.
Thank you so much, Greg, for that very generous introduction. It's always a pleasure for me to talk about helping to make device clinics a little bit more efficient. And I think that's why it's so important for everybody to realize that there are evidence-based guidelines that were published in 2023. They're quite comprehensive, international. There were members from other organizations similar to the Heart Rhythm Society in Asia, Latin America, and Europe. And what was also very nice about it is it included APPs on the writing committee, but very unique to these documents, it also included 4 patients. So we got patients' perspective on dealing with, living with devices and remote monitoring. There are 15 sections, and the sections include roles and responsibilities of a team-based approach to managing a device clinic, credentialing. There's recommendations on staffing and workflows. There are specific tables and figures that describe how you would program devices, how there are suggestions on how you would program alerts, what are some of the timelines for follow-up. There's a whole section on patient education, pediatrics, and how manufacturers and outsourcing, what role they can play in developing an efficient clinic. Next slide, please. So again, there is a figure in the 2023 document talking about all of the sort of tasks that are part of managing a device patients in a clinic, including with remote monitoring. There's connectivity and troubleshooting, and there's a big role for ancillary staff to be involved in, that portion of a device clinic. There's patient education, and enrollment. And so that's everybody's role, really, in educating patients and ongoing. As long as a patient has a device, they need to be continuously educated. So that can be the role of device tech, a nurse, as well as the advanced practice providers. Then there's triaging data and reviewing the data. Again, a team approach. I think technicians and nurses, including LPNs as well as registered nurses, can be the initial lookers of the data from each of the websites, and they are the ones that can contact the entire care team. And there is a lot of evolving options now. We're going to talk a little bit about outsourcing and third-party software to sort of, again, make your clinic a little bit more efficient. And then, of course, there's the final sign-off and alert management that may escalate to a higher, level of licensure, including the allied professional advanced practice provider, the EP physician, and in Europe, they are referred to as physiologists. Next slide, I think. So what is the challenge is in order to run an efficient clinic, to accomplish all those tasks and responsibilities that are included in that efficiency, you need to have appropriate staffing. And we know that from Amber Seiler's work study publication, that remote monitoring, for example, transmissions, just getting the report done, the data read, the report done, takes 15 or more different tasks or steps to get that accomplished. And just maintaining patient connectivity, they identified 17 tasks. So as well as we know that there are, of all the devices, there's only 19% ILRs compared to all the other CIEDs that we implant, but 50% of them are what actually develop the alerts. And so we found that for ILRs, again, when we're talking about appropriate staffing and dealing with data burden, require 9.3 hours per patient per year versus a typical pacemaker, which is only 2.1 hours per patient per year. So what happens is when you have this overburdening of data volume and not an efficient staff, the staff that you have start to feel unhappy, they get burned out. It results in staff turnover, which just leads to further unhappiness because you're working with less staff, or you're having the task of training new people, and it just leads to more burnout and shortages. And so you really need to have a clear-cut workflow design or adjustment if you have one that is not working as efficiently as you may wish it did. Next slide, please. So one of the recommendations in the guidelines is that for every 1,000 patients in device clinic, including remote monitoring, that there be 3 full-time equivalents. And these come straight from the guidelines. It should be a team-based organizational model with formal policies and procedures that should be written out. There should be clearly defined roles and responsibilities. You should utilize clinical as well as non-clinical staff. You want to provide adequate and dedicated time for all staff to complete those remote monitoring and device clinic tasks, and provide enough staff to cover all those unscheduled transmissions as well. And when we talk about team-based, again, it is every clinic is different and unique. I've learned that over the years, that some clinics run just with techs, some just with nurses, some with advanced practice providers. So you have to determine what works best for your workflow, but following these sort of guidelines. Next slide, please. So when we think about best practice and efficiency for device clinics, why APPs should work at the top of their license. So we know that there are increasing cardiac device patient volumes, just talking about all the ILR data that has come through. Now we have, right, cardiac physiologic pacing, more CRT, heart failure diagnostic. So there is increasing patient volume. And the growth in remote monitoring burden now, because of the increase in volume, has really impacted device clinics. And the first document that was published was back in 2008, talking about the importance of device clinic efficiency and remote monitoring. In 2015, Dr. Slotweiner and his writing group actually made it a Class 1A indication, as it should be standard of care for all device patients. But there's also a problem, as Greg was saying, I'm working on this task force with HRS in keeping the workforce available. EP physicians are at a shortage now. And what we're finding is more and more electrophysiologists are retiring, but there's only been a 10% increase in EP trained fellows. So we're going to have increased volume and less workforce at that level. We also have expanding demands for a rapid turnaround in alert reviews, especially the red alerts. And so we really recognize that we need, scalable care models. So what are we talking? We're talking about like clinical pathways. So when you have a patient that is new onset AFib or experience heart failure symptoms with increased ventricular pacing, how is that going to be dealt with? Next slide, please. So that's what we're talking about with the best practice, this potential benefit of having an advanced practice provider integrated into the clinic. And so what are some of the things that an APP can bring? It can improve clinic capacity, right? So if you have an APP who can operate on a higher level than, say, a nurse or a technician, you're going to be able to open more slots in your device clinic, especially to take care of patients that may have had alerts or problems with remote monitoring. Second, you're going to now have a reduced wait for patients to be scheduled because you have, increased slots. Again, it will free up physicians because advanced practice providers have the ability to make independent clinic decision making, that's their capacity. So it will free up electrophysiology physicians from having to be brought into the clinic to deal with those more, higher level issues. And that means that they're free to do more procedures and deal with complex cases. It's going to enhance patient connectivity, right? Because now advanced practice providers are going to be able to do continuity of care with, managing patients for specific problems. And so it will also improve remote monitoring responsiveness because you're going to have a faster triage, faster turnover, and continuity of whatever the management is going to be, over the long run with the advanced practice provider. Next slide, please. And so how can we advance that APP to be able to do that? So everybody's role, to me, in device clinic is really important. And so the utilization of non-clinical staff is equally as important, right? Because the weakest link in a chain, can affect how the efficiency of that strength. So that's why we are saying that non-clinical staff should be utilized, because it can reduce the workload now on the clinical staff. So it frees them to deal with more actionable items, the alerts. It allows everyone to work on the top of their license within their scope of practice. And so who are we talking about? Well, clinical secretaries and administrative assistants can play a role in device clinic management. Medical assistants and technicians who may not be specifically device trained can participate. And then manufacturers' representatives have played a role, and you'll see that in the 2023 guidelines where we talk about how they can enroll patients, they can teach patients how to use their equipment for remote monitoring, and they can give sort of device-specific training, from their particular company. Next slide, please. So again, utilizing the non-clinical staff, putting the role to work. How do we do that? So you're going to develop your clinic with an organizational infrastructure and workflow design based on, again, how you use what particular category of staff. You're going to assign each task based on that staff member's scope of practice under their license. Usually it's state-based. You want to clearly define roles and responsibilities so everybody knows what they are responsible for doing, whether it's a non-clinical member who's making appointments or, connecting a patient to a remote monitoring website, and also each of the clinicals. So what is an RN going to do as opposed to the APP? It has to be clearly defined. And you're going to document that in a policy and procedure manual that we recommend is either electronically or manually available. Why is that important? Because if you also have staff turnover and now you're training new people, you have a manual on what the expectation is for the category of staff that you're hiring. And the other thing that comes straight out of the guidelines is that you really need to dedicate appropriate time, space, and equipment for an effective work environment. There are many centers that, and in my past experience as well, that we were required to go help out with an exercise test or, doing other things that are outside the realm of EP. And the guidelines have sort of more clearly said, no, there should be a dedicated team that deals with device clinic and remote monitoring. Next slide, please. And so, again, what can some of those core responsibilities be as far as a non-clinical person can enroll and schedule patients? As I said, they can provide basic patient education on how and why they have remote monitoring. We're not talking about giving any clinical advice. We're just saying, how does the monitor work? And these are administrative people who have been trained. They can help with connectivity, right? Do basic troubleshooting with patients who lost their connection on remote monitoring. They should know their manufacturer's resource. What's the 1-800 number for Medtronic or Abbott in helping patients with remote monitoring connectivity? And they can also, in some institutions, they keep their monitors in the clinic and are distributed that way or shipped out to the patient. So a non-clinical person can also maintain that inventory. They can maintain and update the manufacturer's websites. People move, they have new telephone numbers, addresses. You want to make sure all that is addressed. And when patients are deceased, that should be documented. They can also triage alerts, again, without making a clinical judgment. In the morning, they can see how many red, yellow, routine people are on the schedule, patients are on for today, and sort of help the team organize themselves for what they have to do for the day. And then in the end, when the reports are done, however you decide that you are sending to referring physicians, and sometimes patients want some feedback. Not every clinic does that, but certainly a non-clinical administrative staff could provide that task and accomplish that. Next slide, please. So when we look then, so if that's what the non-clinical do, what could the other clinical workflow be from triage to final sign-off? Again, every clinic is unique. We have clinics that use registered nurses, licensed practical nurses, and techs. All can help monitor the data across each of the manufacturer's website, do the initial processing, sorting out, again, as I said, what are routine, what the red alerts are for the day and the yellow alerts, and can certainly call patients and arrange for them to come in as needed to be either seen by maybe the nurse if it's not anything complicated, or the advanced practice provider or the physician if they're depending on, the need. The advanced practice provider then, because they have an independent scope of practice to make clinical decisions, can then follow up and see patients who have alerts or issues such as I described with new onset AFib, and can make medication adjustments. They can initiate, for example, anticoagulation for someone who has new onset AFib. They can arrange for further testing if that's needed, or they can escalate the patient to be either referred to another clinic, like maybe heart failure, or perhaps be seen by the electrophysiologist because their decision is that the patient may be a candidate for something like an ablation. So they're going to interpret the transmissions, communicate the results, do the documentation that's necessary in electronic record for reimbursement, and do the billing and the final sign off. And the electrophysiologist as well can do the same. But again, the integration of the APP is to make their responsibility in the device clinic a lesser burden. But certainly they also have the ability to final sign off on complex issues. And again, they're going to deal with those patients that have issues that have to escalate to a higher level of care. And they're going to be the oversight for the overall how the clinic program runs, both in office and remotely. Next slide, please. And I think I am turning over to Julie now, and I'm happy later to take any questions.
Absolutely. Thanks, Aileen. That was great. I think you really laid out a good blueprint and sort of the why, the challenge and the why, and excited to hear Julie talk a little bit about the how, and specifically her how and how she did things today. So Julie, take it away.
Thank you. Thank you, Greg, for having me here to talk about our clinic. We started an independent APP clinic in October of 2025. And here are just three of our reasons, three top reasons why we decided it was important to do that. First of all is that our EP doctors had quite a bit of overflow with what we call our annual well baby checks. The volume just got out of control for them. Their next available for established visits were out 6 months for all of our doctors. They might have 30 patients on their day for clinic, and 18 of them would be a device patient, which was just their annual established follow-up devices. And we knew that our APPs could see that patient, and even whether they were on antiarrhythmics or not, our APPs could handle and take that off those physicians' clinic schedule so that they could then focus on more of a complex patients, new patients, procedural based patient. And so that was a very important to our doctors. And then also just the outpatient demand that was also important to kind of allow the inpatient APPs be inpatient. Previously, our device clinic, our device specialist and our device RNs were doing those clinics, and they're certainly capable of doing that technically. But our patients the acuity is higher now. They're more complex. And so the clinical issues began to be coming up more often. They would come in with AF with RVR or having just more complex clinical issues. And the device specialist or RNs were having to pull our inpatient APPs out and come over to deal with those. And that was disruptive to their day. It was not efficient for the clinic, and most importantly, not efficient for the patient. And so that was a concern. And then also just the complexity of the patient. We have multiple subspecialties in our clinic, heart failure, of course, structural, interventional. We have patients with LVADs, and our patients just needed that person to manage the patient more completely, and our APPs are able to do that. Next slide, please. So this is just kind of an outline of how we do it. Currently, we have 2 APPs, and they are device trained. That's very important to us. They are certified, not IBRE certified, but they're certified. They went through the PrepMD 6-month course, the accelerator, and they currently work 10-hour days, 4 days a week. They do 2 clinic days, full clinic days, and then they staff 2 days managing our remote alerts. And I'll talk a little bit more about that in a few minutes. And then we have device RNs and device specialists, and they staff alongside our APPs. And then they also staff our physician clinics. Anytime a patient comes in for and sees one of our EPs, they get their device checked prior to that visit, and our device specialists or technicians are trained, obviously, and they do those device checks. And then those device RNs and our techs also staff on the remote side as well. And they do some of our loop monitoring and just the device RNs do some of the remote, they kind of triage some of the remote transmissions and get those teed up for the device APPs. And then our EP clinic MAs, they're run the day-to-day clinic operations. They room, they do our monitor education. They work very closely with our APPs. If they're on antiarrhythmics, they'll do EKGs on those patients. They need follow-up labs, chest x-rays. If we're troubleshooting a lead issue, of course, we'll get chest x-rays. They do our follow-up schedules, the keeper kind of the schedule. And then they also quarterback that day for the APP. We get a lot of add-on requests from other teams. And so they're managing that for the APP's clinic. Next slide. Strategies for how we engage and to kind of retain our education. We're all continual learners, all of us. And one of the things that we implemented was that we have Tech Tuesdays, and that is with our manufacturers. The first Tuesday of every month, we rotate. It'll be Medtronic, Boston, Abbott, Biotronic, and we rotate that. And that is a benefit for all of us, the manufacturers and our team. They will introduce new product or new algorithms. We'll have a difficult case study or something we're seeing on remotes, and so that is a great opportunity to touch base with our reps and just sit down and go over issues. And so we've had to pause it a couple of times, but that's been pretty regular for the past 3 years, and that's been a great tool that we use, and our team loves that. And then also, anytime that there's a difficult case or something that one of our members has talked to tech services and learned something, whether it's about an advisory or anything, that goes out on an email. Our team members will share that. And so that is constantly shared amongst the team. If it's something new, there's always something new coming down the pipe, and we want to share that. And so that is just open dialogue, and that's really day to day, week to week, that we're learning or seeing something new amongst all the different devices, all the different lead placements, all the different things. We try to keep that shared communications daily. And then also we recommend not daily, but just feedback. If I miss something or want to have a different kind of, interpretation of something, there's no egos on my team. And so we like to, make sure that patient safety is number one. And that's everybody's main focus. And we all have to have that kind of accountability, and we all feel good about that. We all want to do our best. And so that is a common goal amongst our team. And then credentialing, of course, IBRE certification is recommended, and we, would love that. It is hard and difficult test. We all know that. And, but we do look forward to that with our team. We had one device specialist that passed her exam this past year, and we all celebrated her for doing that. And of course, the working at the top of their license is what we strive for every single day. And also, even the doctor, that's why we started this whole program, is we want the physician to work at the top of his license as well, and not the AFib alerts and the AFib management and all the things that our nurse practitioners manage. They don't have to see, they don't even see that doesn't come across their desk, because our nurse practitioners are able to manage so much for them so that they can handle the more complex patient, the more difficult issues that they need to manage. They're always available. They're definitely, there for us and them when needed. But it really becomes a great working relationship. Next slide. This is another issue that we are very, what we want to promote is the appropriate certification. And when we started looking for our education piece, one thing that we really liked about PrepMD or the accelerator program is it does give you a certification, and that is meaningful. When we started looking 3 years ago, when we lost about three of our really legacy team members, and then also the director left, my previous the director that had this position left, we were really in a difficult time. And so we wanted to hire 2 APPs and 2 device RNs all at the same time. And then also looking towards the change of structure of how our clinic worked with this new APP clinic. Our doctors really expect our team to be the experts and to know all things devices. And so PrepMD was one of the training, the third-party vendor that really stood out, and because it did have that certification that was attached, and I'll kind of talk about that a little bit more later. But that is very important to us that they were able to get that certification. Let's see. PrepMD, as far as how they work is it is 6 months worth of 6-month course, and it's very comprehensive and advanced training, and it starts at really pathophysiology, and it goes throughout for the whole entire from Brady, Tacky, and CRT training, and it is really comprehensive. And the way we work it with our training is that after that big Brady module, then we have the new hire come in to clinic, and we start and have them working in the pacemaker clinic so that they can shadow and have actual hands-on training with the big modules. And one of the best things about the program is that as a manager, you can see the dashboard, and so you can see exactly where they are within their modules. And so if they have check-ins and these quizzes throughout the training, and so if they're struggling with a concept, you can actually pull that quiz, whether it's 25 questions or 50 questions with that concept. You can pull it, print it, and then take that that employee, that RN or APP into a boardroom or a classroom and really get on a whiteboard and work through that concept with them, and then kind of help them through that to where you can nail down that concept, and then they can move on, retake that exam, and so they don't kind of just pass through it and not understanding whether it's sensing or LV pacing or whatever that is. But when we were looking at a third-party vendor to help with the education piece, there was no comparison with the content or the curriculum for the education. And that allowed me, being a manager, to focus on building the program, and being a manager and being out of staffing, and kind of walking beside with the education piece. At the end, there's a 1 week advanced workshop in Braintree, which was fantastic, and everybody loved it, to where they're there for 1 week, and it kind of seals their 6 months worth of training, which we loved, and everybody who's gone through it really thought it was very beneficial. Next slide. I think that's the last one.
Yeah.
Yeah.
Yeah. Julia, if I can add, I just want to say that getting the opportunity to work with all of your folks that you sent to the 1 week workshop is one of the things that, before Kristin goes, is that I heard from each one of them as they came in independently, was the excitement to be there because you, as a manager, were investing in them, and because Centennial Heart was seeing a vision and a future and was willing to take the time to say, hey, go back, invest in your growth, invest in your development, invest in your people, because we'll see. The goal here is that we'll see the return on the end. So for you as a manager, I just really saw that that appreciation that came from Kristin and others. So with that, we'll turn things over to Kristin. Yeah.
Thank you, Greg. Thanks for having me on today. I really appreciate it. And Julie is the best. She's just great. I love working with her. I've known her since I've been here at Centennial Heart. Like you had mentioned earlier, Greg, I've been with Centennial Heart for 10 years this August. So coming up August 15th, it'll be my 10-year anniversary with the company and with the practice. And I had a previous background in interventional cardiology, some EP experience while I was travel nursing and getting my nurse practitioner. And so then once I did get my nurse practitioner, I ended up getting hired here to be with EP inpatient, so acute care. And I was over in the hospital for about 8 years. So tons of good, great EP experience. Knew the bare minimum, that we needed to know the basics for devices, but wasn't device trained. And started getting a little burnout on the hospital side of things. And then, there was a lot of discussion about, revving up this new clinic with devices and APPs. And so I was very interested, and also just wanted to have that final kind of puzzle piece, putting everything with EP together and knowing everything about devices. And so August of 2024, I decided to transition over to outpatient and went through the PrepMD course and went out to Braintree in December of 2024. And it was fantastic. I had a great experience. I feel like have all of my EP experience really helped me go through the course. Like it made it a lot easier for me to catch on to concepts faster. And surprisingly, I knew a lot more than I thought I did, but just really enjoyed the course, and it really, really helped me a lot. And so then have been working on the outpatient side now for almost 2 years. Like Julie had said, I do remote monitoring 2 days a week, and then I'm in clinic 2 days a week seeing patients, whether that be talking about, gen changes or, antiarrhythmic drugs or arrhythmia issues or device troubleshooting or anything. I'll see anything, whatever I need to see, I'll see. And so this is kind of comes to our case study here. This was a really sweet 65-year-old African-American female who had a history of hypertension, hyperlipidemia, and had come in with syncope in August of 2019. She had previously had some Winky Bach, I think, on a monitor, but was asymptomatic. So they had kind of been monitoring, but came in with syncope. While on telemetry in the hospital, they saw that she had brief intermittent heart block, but she also had an abnormality on the interventricular septal wall on her cardiac MRI. Her EF was normal, 60 to 65% on her echo, but she did undergo EP study just to make sure there was no ventricular tachycardia that would have, indicated she needed a defibrillator. Thankfully, that was negative for VT, so she did get a dual chamber pacemaker. It was a Medtronic. Both RA and RV leads were 50-76 leads. And she did great afterwards. And so she fast forward to September of 2025. She followed up with Dr. Borick, routine follow-up. She was doing great. Has had previously no significant arrhythmias, very brief runs of non-sustained VT that were less than 10 beats. And to note, our protocol on remote monitoring that our physicians like for us to follow is if a patient has non-sustained VT lasting 16 beats or more, it's sent to our alert group. We typically like for them to have had either a cath within the past 5 years or an echo and a nuclear stress test within the past 2 years if we do see, some significant non-sustained VT. But followed up with him then, brief non-sustained VT. She has historically, since her implant, she had at that time only paced in the ventricle 40% or even less. 40% was the highest that we had seen. So intermittent heart block is what she had, and she rarely paced in the atrium. Next slide, please. So then fast forward to January of 2026, we get an alert that she's had this 20-beat run of non-sustained VT, and it gets sent over to us to review. And so, of course, she had not had any recent testing. Her last echo was in 2023 as well as stress test. So we recommended getting an updated stress test, an echocardiogram, and then seeing me the same day or a few days after to go over the results of that. The other thing that was interesting about her remote that day, that as we were looking over lead trends, we look at everything. Her trends for her pacing right after she saw Dr. Borick in September, for RV pacing went up to 100%, and she was 100% across the board. So now pacer dependent, heart block. So that was one thing that was interesting. I kind of thought that everything was going to look normal. However, she had her echo on March 13th. The echo was the first thing that I looked at, and her EF was significantly reduced to 30 to 35%. Again, had historically been 60 to 65% normal. So immediately after seeing that she was RV pacing, I thought she's going to have an RV pacing induced cardiomyopathy. But her stress test came back, and she had this fixed defect in the basal anterior, mid to basal anterior septal wall that was consistent with infarction. So I brought her in on the 20th, and it was a very long conversation that she and I had. She was very shocked because she felt great. She's very active. She still works, and she wasn't having any issues that she was aware of. So it was a long conversation between she and I over what could have caused her EF to drop. Could it be a blockage, or could it be from the RV pacing that she was now, 100% basically RV pacing? Next slide, please. So I, again, long conversation with her, talked about getting an arteriogram. That's where we wanted to start to rule out ischemia. So I got with one of our interventional cardiologists, who thankfully worked her in a few days later and did the heart catheterization. Thankfully, that showed normal coronaries. So then I called her and we talked, and I told her that she was going to need to have a telehealth with Dr. Borick to talk to him about CRT, cardiac resynchronization therapy with an LV lead, and trying to get her EF back to normal. And so he spoke with her on the phone on April 1st and talked to her about upgrading her to CRTP. And she underwent the procedure on June 1st, and we saw her a few weeks later in Device Clinic. She was doing great. Device is functioning great. And she's going to follow up with him in September with an echo to see how she's responded to CRT.
So, Kristin, great example there of, I think, everything Julie talked about. Like, how do we, and Aileen, sort of bringing it all together, how do we ensure that continuity of care for that patient, and your ability to take that patient from the, really through implant, through alert, into all of that follow-up and that piece without having to involve the EP at that level. Yet, as Aileen talked about, the ability to free them up to do more, extend more care out to the patient. I think really it's a testament to the vision Julie had in walking into this role of saying, how do we change the way we do things with inside of this clinic? I think Julie talked about, I think there was this moment of, I think actually we were talking the other day, Julie, about this moment of crisis, right? It was a crisis with inside of your clinic. It was the current leader leaving. You had to make a decision about, what do I step into this role or not? And if I'm going to do it, I'm going to bring about a change, right? From that standpoint, it's about empowering people and developing this plan. And you're not unlike many other clinics out there. We talk a lot at PrepMD about this idea of the challenges that take place inside of the clinic, from just the managing the day-to-day that happens, and the burden that takes place, the burnout that happens with regards to staff members. And how do you equip people to meet that challenge over time? So I think a great example that really sort of parallels that, or contrasts with that. We like to talk the device clinic life cycle, the challenges that are out there, and how do you bring about a solution? And we're very proud to be a small part of that solution through providing the educational resources. But it really starts with identifying great people that are passionate about this and are willing to leverage the resources that are out there for you, that you as an organization made available to them. So, we're happy to work with partners like yourself, and excited to, and as we look to wrap things up today, we've set aside some time for some Q&A. So if people have questions of Aileen around guidelines, around the process, Kristin or Julie around their roadmap that they laid out inside of the clinic and the challenges that they felt, will be happy to address those over time. But I think a couple key takeaways that hopefully for the audience is the idea is that this just doesn't happen overnight, right? It doesn't happen by chance. There has to be a plan. And that's one of the things that impressed me about Julie when she talked about it, is that the plan that she laid out, she had a plan. You build that clinic, it doesn't happen. And we have a blueprint to go back to. And Aileen laid that blueprint out there, whether it be number of FTEs that we need for our clinic, providing an environment where the APPs are encouraged to work above their license, that are empowered to do that. And that starts with culture too, inside of it. And, part of that culture is taking time to step back and say, I'm willing to invest in my people. I'm willing to help them get to that next level, because at the end of the day, patients will benefit. And that's really, I think, at least for these three great professionals, and knowing them, that's really what drives them each and every day, is about patients. So with that, happy to take any questions from the group, but I think as we're waiting, I'll kind of throw a question out, some, I guess, questions in general to the group. And maybe I'll start with Aileen. And I know we've talked over the years about your passion around APP. And I think the very first time we ever talked about this was about, hey, PrepMD, have you ever considered designing a program specifically for APPs? And we talked about, well, what's interesting is that whether you're an APP, whether you're that device nurse, whether you're that device technician, it all starts with the foundations and the fundamentals. And what are some of the challenges you've seen at other clinics out there, Aileen, or some things that have amazed you? And it looks like we do have a few things coming in the chat line that I'll check on while you're talking a little bit about that.
Sure. I think, one of the biggest challenges is training people, right? Yep. So we're talking about that whole life cycle, vicious circle that can happen when you get overloaded in your clinic, and people leave, and then now you're hiring new people. And then how do you train them? And honestly, I've been in different institutions where we have had no formal real training. And again, I'm talking about a number of years ago. More recently, I think many programs have come up with a plan for exactly how long it's going to take. And I think that administrators are also putting pressure on clinics to get their, whether it's a nurse, a technician, or an APP, up and running independently in a very short order, right? And as Kristin, I'm sure you can talk about how learning device therapy is a long process. You can't be ready and up and running and independent in, I don't think, a month, 3 months. I think it's at least 6 months to a year. 5 different really manufacturers. They all have their different nuances. Their programmers are all different. Their algorithms are all different. You really need to have an organized system for training people. Julie, I just want to comment. I think that you're having the rep come to meetings, for each of the different companies on a regular basis is brilliant, because I see it where we have someone come into the office that you're trying to troubleshoot, and you're calling the rep to get here in the clinic because we can't, we're not getting it, or you're calling, the technician over, the phone or through your their website. I think the idea of sort of jumping on that before, right? So now you're having your reps teach you, okay, this is the new algorithm, or this is our new product, and that so helps then. Again, be more efficient when you're seeing someone, who has that. Kudos to you for doing that. But I think training is always one of the biggest turnover, and then training is one of the biggest challenges.
Yeah, I agree. And I think I wrote down to myself what she was talking about is how she made it a part of everything that they do, right? You've got to institutionalize it from a cultural standpoint, right? And the fact that it was on the schedule, it was the same time every day, make it habit, right? We all talk about that, everything we do in our lives, making good habits from that. And then just the idea of institutionalizing the sharing of knowledge and cross-leveling that. I think that's, I'm kind of curious, Julie, from a team perspective, like, were people shy at first, or were you, as far as this idea of, hey, we want to encourage this idea of sharing, or things that you see and bringing that up, or did you find certain people that kind of jump to the front to lead on that perspective?
I mean, there's some people that do more than others, but no, it's always been that way here. We had a previous director, Aileen knows her well, Serena Bridges, and so she was phenomenal here, and her and I have always wanted to do the APP clinic too. So, but she laid some great groundwork. And we've always been education. Our doctors expect us to be, the experts, and so we have to maintain that level of knowing what the newest thing that's that's out there. Advisories, we have to be on top of advisories. We have to be on top of new products, all of those things. So it's it's a big responsibility, but that's also what keeps us all here. It's a wonderful, it's rewarding every single day. So that's why those of us who, you know, take our career so seriously, it's so rewarding to have that level of accountability.
Julie, if I could just ask, because I know there's a lot of programs that don't have the support of administration, or maybe they don't have one individual physician champion. And I know even from my experience, when I've gone to administrators, sometimes they just don't get it. And so I guess what I'm asking is, do you have a physician champion, which I always think is sort of important? And did you build relationships with administration that they know what your clinical needs are and they're supportive? Because that can be a real issue.
We do have a physician champion, Chris Jones, who has really gone to bat for us day in, day out, time after time. But we're all very close to our physicians. The rapport is there, and so it has helped very much so. And the support from leadership and admin really has improved, and I will say that tipping point was when Serena left, just because we're such in dire, and multiple people left. So basically the house kind of crumbled, and so we had to make some big changes, and therefore we had to look at education piece. We had to look at the structure of the team, and Serena and the prior manager, they were truly just in name only. And so they were in staffing almost every single day, really was a staffing slot. And so we were truly had to be recognized, a manager out of staffing to manage a team of 14. That had never happened before. And so that had to happen before I was going to take this position. And so they recognized things had to change after all these decades of how we did things. And so that was really the tipping point at that point from our standpoint.
Yeah, so often crisis creates that opportunity for change, right? But if you have to seize on it and you have to lay out the plan, I think too many times people faced with that crisis, they think, how do I just manage through the crisis to get a point of stabilization, but don't think with a longer term vision. I think that's something that you should be, commended for on that side of things. I think, Kristin, I'd be curious as you think about looking back to that transition from the floor into the clinic and from that side of things, what surprised you the most? I know you talked earlier about you were pleasantly surprised about how much you knew, right? And from that perspective and bringing in, but what surprised you the most from what you didn't know, or maybe from what challenges did you face and how did you work through those, or on that early learning side of things?
Probably what surprised me the most is how much it entails, as far, you think the remotes come through and we just review them, and I just had no clue, what each role, like our remote admin, our device admin, our techs, our nurses, everybody, it was just really surprising to me how much does go into to the remote monitoring the device clinic. It's such a team effort, and without one person, it's hard. So I was very surprised at how much actually went into all of the device stuff on the clinic side.
I think that's really telling for someone you were close to it, not in it, but close to it,
Right.
but then to be
Exactly.
surprised to imagine how much administration doesn't know, or
Right.
how big that knowledge gap is there from that standpoint of what really needs to happen and how you really need to be resourced appropriately and to
Oh,
do
yeah.
that.
Yes.
Whether those resources are building out your own team, seeking out the outsourcing help, going to a third party or whatever that is. But I think too often people look at it and says, "Oh, it's a quick fix. We should be able to,
Right.
bring someone in and then, we'll get it figured out."
Exactly.
I think, Kristin, you offered such a great bonus of having so much cardiology experience because you sort of knew how to deal, right, with AFib and heart failure. I mean, that was such a great bonus. And actually, one of the initiatives that the Heart Rhythm Society is doing is they want to develop better guidelines for training, particularly APPs in EP. And they are starting with taking cardiology NPs and how can we make them EPNP. So you would be such a great resource for them. I'm going to mention your name to the people that are on that
I love that.
putting that together because you're firsthand knowledge of it.
Yeah. I mean, I really do. I've said this, I don't know how many times. My EP experience played such an important role in my device training. Like I said, it was the final piece of the puzzle. And I know that I would have struggled. It would have been so much harder had I not had all the EP and cardiology experience that I had. It would have been a struggle to just go straight into EP and device all at the same time. It's such a huge, learning curve. So I do think that played a huge role in my device training and me being able to train a little bit faster. Like I started working on remotes with Julie, I think like a month in, I started helping with remotes and that kind of stuff. And I just would have been able to do that.
Yeah. No, it's interesting you talk about that, the cardiology APP. And, Aileen, we just recently, well, you were there. We were just at the Connecticut ACC doing an educational program. And I know talking about at the local level, ACC they've always sort of looked at EP as that sort of distant cousin, right? And, HRS takes care of all the EP education, but it's sort of at a local level, we're seeing here in New England, this, how do we better educate that our community, that being the ACC community around EPP. And I think they're trying to take that more of a national level from an educational standpoint also. But, I think the more we can learn, the more we can know across is important. So the couple questions here, and I was looking at the chat line and I didn't realize that they're in the Q&A section of the thing. Where would I have thought? Why would I have not looked in the Q&A section? I think there was one person commenting that one of their biggest challenges is getting leadership to understand the importance of the structure of the device clinic, why we need RNs, techs, MAs, schedules, and I think we've done a nice job answering that. But I don't know if there's any more anyone wants to add into that about the structure, and from that piece.
Well, I can just say that when the reason why I became the co-chair for that writing committee is because I lived it. I know that's a big challenge for you. It was for me. And, I knew that we needed guidelines because if I go into administration, they would say, well, are there studies that are done? Is there evidence that shows that you need, multiple people involved with the device clinic? So one of the things we did try to do, so I would refer you to the guidelines and making sure that leadership, your administrative leadership is aware of those because the evidence is there. And we also have some educational derivatives on the Heart Rhythm Society website. And one of the ones we did provide was because the document is very long, right? It's I can't remember exactly how many pages, but what key points should you make to your administrators? What would they need to know to help you be supported in your clinic?
Yeah. Speaking of the guidelines, there was another question referencing the 3 FTEs per 1,000 remotely monitored patients. So they're asking for a little bit of your thoughts on a recommendation around a clinic that has 1,000 patients with remote monitoring in clinics and inpatient checks as well.
Oh, inpatient. So what we were looking at was the evidence of running a device clinic, looking at patients in office and remote monitoring. And we recognize that there are other things that you're, needing to do, like inpatient checks. And I don't know if you're involved with MRIs and, pre-surgery and all the other things that go with it. What I guess I would say is that the guidelines do look at inpatient remote monitoring. It says 3 to 1,000. If you have other additional tasks and responsibility, like inpatient checks and anything else I mentioned, then that number should, go up.
No,
I have
absolutely.
one thing quick to say, Greg, about
Yeah.
that admin or leadership. I became really close friends with our billing manager. And so that they need to understand that our APPs are billable. So every patient that they see in clinic and also our remotes, they sign their own remote transmissions. And so they're not only taking that off of the device, off of the physician template, but they're billable. So all of those device clinic patients, all of those encounters, all of those office visits are billable now. So they need to understand, and we did a lot of mock workups with numbers. They need to see numbers. They need to see dollars for this APP and what that they can bill for. And so we did a 6 month, and their numbers are incredible for what they've done these past 6 months. So I think that's where a good way to kind of versus just we need. This is what we can do for you.
Exactly.
Yeah.
They hear speak their language.
That's right.
And
All
so
of
I
them
think a related question just came into that as we push up on time. Is reimbursement less for APP signing off and remote monitorings versus the MD?
It's we talked about this. For us, it's 85%.
Hmm.
But again, our physicians are certainly fine with that. They still sign their own, like all the normals that come through, they all go to the physician. The ones that the APPs manage on remotes, they manage it and they sign their own. So it's a small percentage, but it is the percentage that they do not want to have to deal with or manage. So that would be 85%. And again, the ones that they're seeing off in device clinic, they're seeing a higher complex patient in clinic or one that could potentially become a procedure. So it is the model does work.
And I
Right.
think I know in New York it's also 85%. I don't know if that's a state-based, if
Mhm.
it's different in different states, but I would recommend that people do ask what their
Right.
state reimbursement is for APPs independently seeing patients.
Yes.
Great feedback. And and we're pushing up on time here. There was one last question about their thought around designing certification for device clinics, which includes all the structural education follow-up skills needed for the entire workflow related to device management. Individual certification is great, but tough to pull all the pieces together for a high-level program. And I think that's a really great insight. And it's interesting. That's I would just say, PrepMD is kind of our perspective when we look at working with the clinic. We try and think about that clinic as a whole. Matter of fact, Omni, our remote monitoring software, we think of it as a device clinic management system. And how do we help you manage workflow? How do you help you manage staff development over that standpoint? And I know when we go in and we work with our clients, that's one of the first things we do is we talk about workflow improvements. How do we partner with you as an entity? But I love the idea, and maybe that'll be our next educational program is around the entire clinic as opposed to the individual from that standpoint. But
And there is,
I just
I wanted to say, Greg,
yeah
quickly, and there is a precedent for that because there
yeah
are AF, centers of excellence.
yes,
It may have criteria that meet that. So it would be great. I think that's a really wonderful idea to do that for device clinics as well. Device.
absolutely. Absolutely. So maybe we'll get you three on that committee. So I just want to say thank you. It's been an honor to work with three great professionals preparing for this session and listening to you and continuing to learn from you. Your passion for patients and what you do each and every day shines through. And thank you for all that attended today. I want to thank Kate Murphy, who behind the scenes put all this together for PrepMD, and we'll be making this recording available for folks and their access later. So thank you all and enjoy the rest of your day.
Thanks a lot, Greg. Bye,
Thank
everyone.
you.
Thanks for having us.
Yes.
Yeah.